بسم الله الرحمن الرحيم. السلام عليكم طلابنا طالباتنا الأعزاء المرحلة الخامسة. We will discuss today cerebral palsy, which is the first lecture in the neurological series in pediatrics. So cerebral palsy by definition is a disorder of movement and posture. It is a non-progressive disease involving the motor pathway. And as we said, it is a non-progressive, but at the same time it emerges in a clinical presentation over time. This means it starts to appear earlier in life, and with development of the motor function, which is mainly occur in the first year of life, and there is defect in the development of this motor function. The sign and symptoms appear gradually, which give an impression of a progressive disease, but actually it is non-progressive. So the cerebral palsy is the most common cause of motor impairment. It affects about 2 per 1,000 live birth. In addition to the disorder of movement and posture, because it is of motor function origin, usually it affects also other part of the body. It causes many brain dysfunction, including learning difficulties in 60%, epilepsy in 40%, sequent in 30%, visual impairment and error of refraction 20%, hearing impairment 20%, speech language disorder, behavioral disorder, feeding disorder and problems, and joint contracture as a hip subluxation, and there is scoliosis. So what are the causes of cerebral palsy? If you ask anybody, ask you what are the causes, usually it is intranatal or during antenatal in origin. So we have 80% of CP is due to antenatal in origin, usually due to structural abnormality, migration disorder defect, developmental defect, and some problem like gene deletion, genetic syndrome, congenital infection, torsacrine, toxoplasma, rubella, cytomegalo, and herpes. This is due to maternal infection. And another 10% cause to be due to hypoxic ischemic encephalopathy at birth, and this is because of obstructed labor, difficult labor. There are many causes for hypoxia during delivery, and this includes only 10% of the causes of cerebral palsy. Another 10% is postnatal in origin, which include, first of all, the preterm. Preterm infants are more liable to have cerebral palsy. Why? Because their brain, they are not developed yet, and any damage, any stressful event causes harmful effect to the developing brain. And there is damage occur from the periventricular leukomalacia and severe intraventricular hemorrhage. They are vulnerable to these complications. So the rise and survival of extremely preterm infant has been accompanied by an increase in survivors with cerebral palsy. Other causes of postnatal origin, in addition to preterm infant, is the infection due to meningitis, encephalitis, or head trauma, whether it is accidental or not, and hypoglycemia, which is a metabolic cause, usually symptomatic hypoglycemia. It carries a high risk of cerebral palsy, hydrocephaly, and severe neonatal jaundice, which is a hyperbilirubinemia, usually above 20, and in those who are low for gestational age or premature baby, or even full term with other risk factors. And we have the seventh cause is a thromboembolic phenomena, and they are liable to have neonatal stroke. So what's the key of a clinical presentation? How did they present? Earlier in life, early features in infancy, there is abnormal limb tone, and the lip and or the trunk posture, abnormal tone, abnormal posture, and there is delayed developmental milestones, and we are talking about the motor milestones. There is slowing head growth, and there is feeding difficulty with oromotor, incoordination, slow feeding, gagging, choking, and vomiting. There is asymmetric body movement, and there is a hind preference before 12 months of age. The primitive reflexes may persist and become obligatory, and abnormal gait once walking is achieved. So the early and the key manifestation is delayed developmental milestones, neurodevelopmental, and there is abnormal posture, abnormal gait, and feeding difficulty with asymmetrical movement and hand preference, and there is primitive reflexes remain obligatory and persist. This is a baby or a child, as you see here. He has a history of cerebral palsy. You can continue this video later on, and we will discuss other subject. So the diagnosis is made by the clinical examination with a particular attention to assessment of the tone pattern in the limbs and in the trunk and posture, hand function and the gait. So clinical examination of a baby with cerebral palsy start to look and you have to check the body as a whole, the posture, the limbs position, the tone, hand function and the gait. So what are the types of cerebral palsy? We have, how many types we have? We have 4 types. First of all is the pyramidal tract involvement. We called it the spastic cerebral palsy. It is about 80%. Extrapyramidal tract, there are 2 types, ataxic, hypotonic. We call it is about 10%. We call it cerebellar, as there are cerebellar signs, and ethitoid CP or chorioethitoid, or we call it the dyskinetic CP. It is another 10%, involve the basal ganglia. These are the pyramidal and extrapyramidal, and there is other type, we call it the mixed pattern. It is 10%, mostly spastic and ethitoid. So here we have the cerebral cortex, and we have the left and right side. If we call this lateral section through the as know, there is the motor area, the perigyrus, the motor area. Here what we have, if we take this lateral or cross section here, we see that this is the area responsible for the motor function, and any area in this part in the cortex, it is supplied by nerve fiber, and it is collecting the left. It will goes and decussate through the pons and the ganglia and the medulla oblongata. It will goes to the left. The left side goes to the right side, and the right side goes to the left side. This is the innervation, the motor innervation. It arises from the cortex and then pass through the medulla oblongata to the spinal cord. So in this area, which area here is responsible for the upper and lower limbs? If the area here is affected, damaged by any mean, by any cause, the lower limb will be affected. If this part is affected, so the upper limb is affected according to the area which have damage, and whether by ischemia or by bleeding or pressure effect or whatever. And this is the facial part. So we have the upper limb, the lower limb, and the facial part. Here it is, we call the cortex or the pyramidal part. If there is a lesion in this area, it will end with the spastic cerebral palsy. The patient is stiff and there is difficulty in movement, and as we said, it is about 70 to 80% of the CP patient. If the lesion here in the basal ganglia, there is dyskinetic cerebral palsy. Also, there is involuntary and uncoordinated movement. While if it is here in the cerebellum, there is ataxic cerebral palsy. There is disturbed, as we see, the sense of balance, and there is a tremor. Or we have the mixed type if all the area is affected here. So this is, as we said, the motor area and reflection of the lower limbs, the upper and the facial parts. If there is any damage in any area, it will be reflected to the motor area, which supply these organs in the body. And as we said, spastic is 70 to 80, dyskinetic maybe 6 to 10%, ataxic 6 to 10%, and there is a mixed type. So what are the character of the spastic cerebral palsy? There is damage in the pyramidal, or we call the corticospinal tract. The limb tone is increased, that's why we call it spastic. With brisk tendon reflexes, the deep tendon reflex is very brisk, and there is positive Babinski sign, which is the extensor plantar responses. There is increased limb tone and sudden yield under pressure. We call the clasp knife fashion. The clasp knife fashion. So, early spasticity, even in the neonatal period, is a sign, and sometimes precipitated or preceded by initial hypotonia and especially this appear in the hand and the trunk. So in spastic CP there are three main types. First of all, we call it a spastic hemiplegic. From its name, hemiplegia, so that there is half of the body on the longitudinal section, half of the body is affected, unilateral involvement. It involves both the arms and the legs, so it affects the arm and the leg on the left or right side. The arm is usually affected more than the legs. Here the arm is affected, but to a more extent than the leg, and the face is spared. Usually there is twisting of the affected hand, and it is present from the 4 to 12 months of age, and there is a flexed arm with a pronated forearm and asymmetric reaching or hand function. So the hand is abnormally functioning and abnormal position, and there is abnormal twisting. And hand preference at a very early stage before 1 year of age. There is delay walking and circumductive gait, and there is a tiptoe walking on the affected side become evident. The toe, we call it the toe heel gait on the affected side. The affected limb may initially be flaccid and hypotonic, but the tone increases with time, and it will remain a prominent sign. The past history here is normal, unremarkable. There is no history of hypoxia or ischemia, but some condition caused by neonatal stroke. This is, as we said, the circumduction movement. There is circumduction movement, and as we said, there is twisting hand and the pronation of the forearm. And here is very obvious with a tiptoe movement. These are characteristic of hemiplegia. Seizure occur in the first 2 years usually, and 25% of patients they have mental retardation. By CT or MRI study of the brain, there is atrophic cerebral hemisphere and dilated lateral ventricle in the contralateral part to the affected extremity on the opposite side of the affected extremity. So when we examine the involved extremities, the upper and lower limb, what we found, as in this patient, there is a growth arrest, and there is spasticity, equinus deformity, as here, this is an equinus deformity, you see, of the foot, and increased deep tendon reflexes, and ankle clonus positive Babinski sign. It is unilateral, and this is the picture of a unilateral involvement. We call the hemiplegic cerebral palsy. What about diplegia? Diplegic cerebral palsy. Here all the 4 limbs are affected, but legs are affected more than arms, while in, as we said, in hemiplegia, the arms affected more than the legs. The hand apparently normal, but the functional use, the motor difficulty appear. With more functional use, the more difficulty appear. In severe cases, even the application of diaper is difficult because of excessive adduction of the hip muscles. And when the child suspended by the axilla, if we remove the child from below the axilla, there is scissoring posture of the lower limbs. There is decassating of the limbs over each other, and it is maintained because of strong adductor muscle contraction. And in addition, there is disuse atrophy and impaired growth of the lower limbs in severe cases. The child may be unable to sit, and while crawling, the child uses the arms in a normal reciprocal fashion, but tends to drag, to pull the legs behind. And walking is abnormal and delayed. The feet here are held in position of equinovarus, as we said before, and walk on tiptoe. Subluxation dislocation of the hip is relatively common, and there is the intellectual development here is normal and excellent, and the likelihood of epilepsy is minimal. In diplegia, as we said, the forelimbs are affected, but the legs is affected more. Usually the lower limbs is affected, but there is no convulsion and intellectual normal function. Examination here, as we said, there is, if he is, as this baby is infant, there is a crossing or scissor positioning of the legs. There is the cassating of the legs over each other because of spasticity and severe contraction of the hip muscles. There is equinus deformity, as here, as you see here, the equinus deformity is apparent, and increased tendon reflexes, and there is ankle clonus, and there is bilateral positive Babinski sign. And here we have type of crawling. The crawling here is different from other types. Crawling here, the baby is using his both hands, both arms normally, but he draw the legs. This is a picture which gives an idea about the hemiplegia, the paraplegia, and we have the quadriplegia. What do we mean by quadriplegia? All the forelimbs are affected severely, and the arm may be affected more than the legs. The trunk also involved, and there is extensor posture and poor head control with a low central tone. There is increased tone spasticity all over extremities and decreased spontaneous movement. There is a brisk reflexes. The flexion contracture of the knee and elbow, there is a deformity in the knee and elbow. Swallowing difficulty is also common due to the supranuclear palsy, which lead to aspiration pneumonia. They got aspiration pneumonia and might end with death. Profound developmental delay. It appears early in life with a developmental disability, including speech and visual abnormality. It is highly prevalent in this group and often associated with seizures, microcephaly, intellectual impairment. There may be a history of hypoxic ischemic encephalopathy. So quadriplegia is the most important one. It is the most severe type. All the limbs are affected equally. There is spasticity all over the body, abnormal posture. There is poor head control. They got difficulty in swallowing. They got recurrent pneumonia and developmental delay, visual and speech abnormality, and there is seizure with intellectual impairment, and the history goes with a history of hypoxic ischemic encephalopathy. This is a picture of a child with a quadriplegia. So what about ataxic? Ataxic hypotonic cerebral palsy. Here we have cerebellar lesion. The signs are relatively symmetrical. There is early trunk and lip hypotonia and delayed motor development. In coordination, there is incoordinate movement, there is poor control of the movement and the poor balance, and there is a wide base gait. In addition, there is intention tremor, and ataxic gait may be evident, but it is a later sign, reflecting dysfunction in the cerebellum, or it is connection. So we have athetoid cerebral palsy or chorioathetoid cerebral palsy or extrapyramidal cerebral palsy. Here the affected children often presented with floppiness and poor control. They are not spastic, they are floppy, and they are hypotonic. There is delayed motor developmental in the infancy, and there is abnormal movement, sometimes not appearing before the first year of life. These infant characteristics, as we said, they are hypotonic, but rigidity, dystonia may develop over several years. Dyskinesis, which is a fluctuating tone leading to frequent involuntary movement, especially evident with movement or stress. These involuntary movements are either chorea, which is an irregular, sudden, and brief, non-repetitive movement, or dystonia and athetosis, simultaneous and sustained contraction of agonist and antagonist muscle. The muscle are antagonize each other, involving the trunk and the proximal limb. Dystonia and the distal part, we call it the athetosis. Intellectual here remain unimpaired, mostly associated with birth asphyxia. Also, it can be seen by kernicterus or whenever there is a basal ganglia lesion. It is less common, it is only 10% less common than spastic cerebral palsy. So how we manage patient with cerebral palsy? First of all, patient should be given details of diagnosis. The parent should have the diagnosis but not the prognosis. And children with cerebral palsy, they have a wide range of medical, psychological, social problems, abnormal speech, language, and a child may have deficit in either receptive or expressive speech or language, or maybe both. So the treatment here need a team of physicians from various specialty as well as physical therapist, speech therapist, social worker, and developmental psychologist. The management here involve, first of all, management of the common associated disability and the health problem, and as well as the management of the consequences of the motor disorder, like scoliosis, hip subluxation or dislocation, and so on. So spasticity management, first of all, we have medications. Start with treatment like oral dantrolene sodium or the benzodiazepine and the baclofen. The intrathecal baclofen has been used successfully in selected children with severe spasticity, just to decrease the contraction, as it causes severe pain, and the spasticity is painful condition. Other, or the third treatment, is botulinum toxin injected into a specific muscle group, may be used for localized spasticity. And other mode of therapy is a rhizotomy procedures, which is a surgical division of the dorsal spinal root, may be also used to relieve spasticity and spastic diplegia. Thank you so much.